exclusively on Secular Media Network. This is the Gaytheist Manifesto.
Hello and welcome to the Gaytheist Manifesto, your source for news, commentary, discussion, and debate at the intersection of the atheist movement and the LGBT rights movement. I am your host, Callie Wright, joined once again by my co-host, Ari Stillman. What's up, Ari?
Oh, you know, butt stuff mostly.
For context, that's Ari's Skype status consistently. Just butt
stuff.
Yeah, which is...
This is what happens when this is literally the fourth thing that we have done today for the show, and I'm just tired. I'm just so tired. I hate talking. Why do I do a podcast?
On the show this week, we want to talk about the intersection of science and social justice. Anyone who's familiar with atheist community discourse knows that sometimes there seems to be sort of a disconnect between people who value scientific skepticism and people who value social justice. And I think there are a lot of times people on either side of the equation who make the assumption that one side is not necessarily interested in the other. We end up talking past each other. And obviously on this show, we come very much down on the side of social justice, but I don't think that coming down on that side means that you have to ignore scientific skepticism. In fact, scientific skepticism is what led me to the things that I value and the things that I see as right and good. So on the show this week, we have a physician and scientist, Dr. Tara Lagu. Welcome to the show.
Hi, thanks.
So why don't you just give us a little bit of your background? Tell us your story. Tell us, the background on why you do the work that you do.
Sure. Yeah. I grew up in Indiana. I am the daughter of a former Catholic nun and a very devout Hindu. My dad's from India.
Ooh, interesting combination.
It's a miracle I was born. My mom is from Cincinnati, Ohio. My dad is from near Mumbai, India. He's from a smaller city in India. My parents met as graduate students at the University of Cincinnati. And I ended up, my dad worked a bunch of different places, but I ended up growing up in Carmel, Indiana, which is a very white, wealthy, and highly Christian suburb of Indianapolis. I had a great youth in a lot of ways, but it was also very clear from the beginning as a half Indian, gender non-conforming, soon-to-be gay kid that I was very much in the minority in my town. And I ended up going to college at Purdue University, which was not that far from where I grew up, and not that different from where I grew up. It was pretty white, pretty conservative, pretty Indiana, and to be who I was in a place like that, both in high school and college, I really had to find my voice and figure out how to both express who I was and who I am, and also, try and navigate this world that I was so different from. And it really taught me a lot about how I wanted to live my life, and I think it really shaped what I ended up doing with my career.
Very cool. And so what did you end up doing with your career?
Well, I as an undergrad, I majored in pharmacy, actually. I became a pharmacist. I'm still a licensed pharmacist in the state of Indiana, although I just made my license inactive because I really am banking on not having to go back to Indiana and be a pharmacist. But I guess, after I did get a pharmacy degree, I am a licensed pharmacist, but I ended up going to med school and doing a public health degree. And somewhere along the line, I'd worked in the lab as a pharmacy student. I had done, sort of like basic science, bench science as a student. And I'd always thought I was going to love research, and I just wasn't that enthusiastic about it. And then when I got to med school, I found out that there was this whole branch of research that I had never really heard about before. And that was sort of public health research, or what I do now I call health services research. And it's basically, it's focused on a lot of different things. I mean, I'm actually a terrible researcher in the sense that I don't have, I'm not passionate about lanternfish or something. I'm passionate about a lot of different things.
Well, those things are important, but not everyone has to. Yeah.
So, in the science world, a really good researcher is somebody who just cares about one tiny question and hammers that question for the rest of their life.
Right.
Right.
That's not really me. I ended up, being passionate about a lot of different things, and it was because of the fact that I had gone through a lot to become who I was. And so I sort of took the lessons of trying to come out and be a person of color in a place where there were not that many people of color, and there were basically no gay people. And honestly, there were no trans people. I didn't know any trans people in college. Although eventually some of my friends transitioned in college. At the time, nobody was out as being trans. So, I'd been fighting for my rights in a pretty passionate way for a long time, and I needed a way to continue doing that in my career. And so when I found sort of public health research, health services research, I realized there was this whole, body of work that was really focused on asking questions about how to improve health for all. And that includes equity and equality of access to healthcare, of delivery of healthcare, and of outcomes of healthcare. And suddenly it was like, the key fit the lock. For the first time, I suddenly realized like this was something that brought together all the things I was passionate about in my life, that I had been really passionate about trying to make sure that people who were of different sexual orientations or different gender expressions had equality in my college experience. I was really passionate about racial disparities in access to health and healthcare, and later on in disability and access to health and healthcare. And those questions, are the things that really get me up in the morning and get me to do the work that I do.
And were there any specific things that you saw, getting into this? And was there kind of a light bulb moment that was like, holy crap, like this is what I need to do. This is where I need to be going. Or was it kind of more of a slow burn that just kind of pointed you in that direction?
Even before I interviewed for medical school, I remember hearing on the radio, on NPR, of course, because NPR...
Right, because NPR, yeah.
NPR shapes our lives. I was, I think, driving to med school interviews, and I heard this piece on NPR about, and it was like, I was 1996 probably, and I heard this piece on NPR about California's plans to deny prenatal care to people from Mexico who were undocumented, basically. And I guess people from anywhere who were undocumented, but the primary group they were focusing on were Mexican immigrants who were undocumented. And I heard that and I thought, that is terrible. That is exactly what is wrong with healthcare in the United States. And if I'm going to be joining this group of the group of people providing healthcare, we have to figure out how to stop policymakers from implementing these kinds of terrible policies. And so I sort of had this, I remember talking about that NPR story during my medical school interviews. Like, this is something that I already am fired up about. And of course, you sort of think, well, I was going to med school, I thought, well, as a doctor, I will be able to address health inequity, patient by patient. And I rapidly found out, even as a medical student, but certainly as a resident, that if I was going to try to make change patient by patient, I was going to be hitting my head against the wall for a long time. And to me, I needed to figure out a way to address these questions that I was passionate about in sort of a bigger way. And so I'd already started doing a little bit of research. I was doing research on prostate cancer early in my med school years. I ended up doing a public health degree sort of in the middle of med school. And I knew then that I was probably going to focus my career on a combination of clinical work and research. And it just so happened that I went to a residency program that was very focused on providing free care and care to low-income people. I was a resident at Rhode Island Hospital. And that, like, my passion around sort of addressing disparities in health and healthcare really increased during that time. And some of the things that I saw during that time reinforced my passion for the subject. So I definitely saw how different access to care was for people with different kinds of insurance, for example. I definitely saw, the one I always think of was this patient with cancer who didn't have health insurance, and she ended up dying before a patient with insurance would have died, in my opinion. Like, I really believe that. I think that her difficulty with accessing care, even as a cancer patient, led to her death earlier than it should have been. And so, I was fired up. I definitely wanted to do it, but I didn't really know how to channel my energy. And so I ended up doing this fellowship program called the Robert Wood Johnson Clinical Scholars Program, which really their focus, is all kinds of, research that attempts to reduce inequities in health and health care for all kinds of different groups of people. I mean, they focus on, racial minorities, refugees, women's health, community-based participatory research, trying to get communities involved in health. They really have a lot of different areas of focus, helping people understand health information better. And so it was a great opportunity for me to learn how to do this kind of research. And it set me up for the moment when, really I found the thing that I felt I needed to work on. So there's this whole literature, the health services literature is full of examples of racial inequities in health and healthcare. And there has been a lot of work on that. And again, there's so much to do still. And there are many very smart people working on that. And so, I was passionate about that, but it's, in research, you also have to find your area that, to really get a foothold to be, the person who does that. And you have to be able to get grants in a subject. And so I sort of needed to find the thing that was going to be my thing. And then I was seeing patients as a doctor where I work now, in Springfield, Massachusetts. And I had a patient who had a stroke, and she'd had a stroke a while ago, and she was not doing well at home. She was had a couple of hospitalizations, and she was not doing well, and she needed to see a urologist. And because she'd had a stroke, she used a wheelchair. She could not walk on her own. Half of her body basically did not work. And I said to her daughters, you are so attentive. You're just such attentive caregivers. I can't imagine why you haven't gotten her to see this urologist yet. And they said, well, we can't find a urologist who will see a patient who uses a wheelchair. And I thought, that's...
Wow.
I know. I thought that's really unbelievable. That's not... I didn't believe it. And I pulled one of these, I'm the doctor. Let me make some calls. But when I called, I found out, in fact, it was true that no urologists within 100 miles of this woman's home would see a patient who used a wheelchair. They required her to hire an ambulance to take her to and from, and have EMS folks transfer her from a wheelchair to their exam table. And her family didn't have money for that, and Medicare doesn't pay for that. So she just wasn't able to see that kind of doctor.
How is that legal? Or is it legal?
It is not legal. It is the Americans with Disabilities Act and the part of the Rehabilitation Act, both require that physicians accommodate patients with disabilities. But although it is not legal, it is very difficult to enforce. So as a result, and there's all these other things that go into it. So, physicians aren't trained how to take care of patients with disabilities. There's all this sort of, it's a long cultural process that results in this moment where this woman who uses a wheelchair suddenly can't find a doctor. But it is true that it is a violation of the law that no doctor would see her. But it wasn't like you could call the police to enforce it, right? It was a little more complicated than that.
Right,
She'd probably have to sue, and she's probably not in a position to be able to afford, a lawyer to bring a lawsuit against these doctors.
Exactly, and I actually offered to put her family in touch with an organization called the Disability Law Center that takes that kind of initiative for patients here in Massachusetts. But, people don't want to sue their doctors. They don't want to sue doctors in general, but they really don't want to sue their own doctors, people they already have relationships with. And
it's so much emotional energy and effort while you're already dealing with a health condition that takes so much of your time and energy already. Like, it's vicious.
Exactly. And so, I think the family was just like, yeah, that's not really our style. And so then I'm like, wow, there's probably a lot of patients who are left with this situation. And so that led me to lead a study where we actually basically did like a secret shopper. We called doctors' offices across the country and asked them, and we called as doctors, and we said, will you see a patient who uses a wheelchair? And what we found was that it was all subspecialists, that was not primary care, but across a variety of subspecialties, 20% of doctors said they would not make an appointment for a patient who used a wheelchair. And of the rest, it was pretty unbelievable. 20% is a big number. And particularly if you live, in an area where there's not a lot of doctors, that could mean that you don't have access to certain kinds of doctors at all. And then among the people who would see a patient who used a wheelchair, about half had really kind of unbelievable plans for how they were going to go about seeing that patient and how they were going to transfer that patient from a wheelchair to an exam table. And so, we had people telling us that the parking attendant was going to come inside and help to transfer the patient. And that's just, frankly, not safe.
Right.
And in studies of patients who use wheelchairs, they report real fear of being dropped or being injured at doctor's appointments. And some have been dropped or have been injured at doctor's appointments, probably from just this kind of, sort of schemes to get people onto exam tables. So
why don't they just move somewhere where there are better doctors? Come on, people, free market, personal responsibility.
God.
Right. So, of course, I know you're joking because...
Yes.
I hope that's clear. I've gotten in trouble before for these kind of things.
If only it worked like that, right? It doesn't work like that. And you're talking about, particularly among people with disabilities, are some of the most vulnerable members of our society, right? Hillary Clinton just gave a speech about this. People with disabilities have such difficulty in finding housing, in finding employment, in finding... this is just one more... thing to burden people with disabilities with. And it's unbelievable, but in fact, they can't find doctors either. So
what's the justification for this? I have to believe that these doctors aren't mad scientists twiddling their thumbs people with disabilities, I hate them all. How do they justify this?
No, you're absolutely right. And I think, one of the other things I've learned in my life is the best way to change someone's behavior is to first try to empathize with their situation.
Right.
And figure out what is happening on the other side of this equation that's leading to this. And, I have a good point of view to think about this because I am still a practicing clinician and I do know the pressures that doctors are under. And so I understand in some ways how it happens. I went to a very progressive residency program. I did not receive training in how to take care of patients with disabilities. So it starts with education. But it goes beyond that, which is that doctors are struggling they're treading water in their daily life. So right now, a doctor has to see, I don't know, it just depends, but it can be like 16 to 20 patients in a 4-hour period, which is, if you think about that, it's almost impossible to think about how you would have a meaningful conversation with that many people every 4 hours. Right. And also, by the way, document it in the electronic health record. And also, I mean, it's actually, it ends up being the situation where you are working 12 hours a day just to work 8 hours a day. And so I think doctors are on the other side feeling overwhelmed, feeling like they're not getting reimbursed. And when it comes to patients with disabilities, because they don't have systems in place to make it easier for themselves, they suddenly see the situation where, and I've experienced this, where I'm in clinic and I walk in and I see a patient in a wheelchair and all of a sudden it's a disaster because I realize, oh no, who's going to help me transfer this patient to this ridiculous exam table that doesn't lower? How am I going to examine this patient? Like, it's all of a sudden a disaster. And so over the last couple years after that study, I've really tried to do a couple of things. One is to write papers about educating doctors around how to accommodate patients with disabilities, write sort of policy pieces about how to, from the enforcement side, encourage doctors to see patients with disabilities. And also, like, how can we reform this system so that it's not so difficult to accommodate a patient? And of course, there are lots of ways to do this. We have to change the way we practice. We have to change our culture. And that's a big, prospect. But I really believe to achieve equity for this very vulnerable group of people who, by the way, as doctors, we promised the day we became doctors to protect, right? We promised to do no harm to our patients. We promised to try to protect patients who did not have other means of, becoming well. We're it. We are, as doctors, we've committed to this. We've committed to social justice just in becoming physicians. So I really believe it is the responsibility of our profession to figure this out. And so, I've written a couple of grants. I'm going to continue to write grants to think about how we can both change sort of some of the sort of logistical pieces around healthcare to better accommodate patients with disabilities, and how we can change our culture, the culture of physicians, so that we have a different attitude about how to go about this.
Right. And so kind of taking it to the next logical step, how do we use science to fix these problems, or at least get them, to start moving in the right direction? I mean, obviously, using, studies like you did to just lay out the scope of the problem. And, it really is this bad. There are this many people going underserved or completely unserved, and it's disproportionately, people who are, in other ways marginalized in society, people with disabilities, LGBTQ people, racial minorities, so on and so forth. So how do we apply science to not only, figure out the problem, but then solve it?
So the figuring out the problem is easier than the solving. And I guess that's true for anything, right?
Right.
But we've done a pretty good job, in health services research of identifying disparities in access to care, disparities in delivery of care, and disparities in outcomes of care for patients who are racial minorities, for people with disabilities, for LGBT people as well. Certainly, there are disparities across the board for those groups. And it stems from a lot of different things. It stems from, certainly stigma and poverty and what hospital you go to and what kind of insurance you have. And it's a lot of things. And so we've done a great job of saying, boy, if you look at African Americans, their cancer is diagnosed later than people with the same cancer who are white. If you look at African Americans with breast cancer, they die more often than people who are white who have the same kind of breast cancer. And then there's this, then you get into this problem like, okay, how do we address this? Well, so there's all these arguments, right? Like, is there a biological basis for this? Is it that the cancer is different depending on your race? Seems unlikely. I mean, there's not a lot of good evidence for the biological basis of race no matter what. So that doesn't really seem right. Okay, so maybe it's access to screening. Well, okay, so if it's access to screening, how do we change screening? Oh, maybe it's stigma in the community about mammography, or maybe it's something else. Maybe it's, people don't have insurance that pays for mammography. Maybe it's that people who are African American see different doctors and those doctors don't recommend screening. And so it's like this huge mass of how do we get to the bottom of this? And I think, as health services researchers, we're trying to be better at getting to the bottom and solving it and thinking of interventions that will start to address all these potential points. But I have to say, we're not as good at it as we could be. And I wish we were better. And frankly, I identified this problem of access for patients with disabilities, and I wish I could be better at solving it. Because it's so incremental and difficult, and there's so many aspects to it that I am sometimes overwhelmed and I don't know how I'm going to approach it. And also, it's hard to get money to do any study. And so part of my problem is that I've spent a couple of years trying to get money to do these kinds of studies, to take the next step towards an intervention that would start to address this problem. In the meantime, I've written a ton of papers saying, here's what we should do. Here's the way to address this. We should stop paying doctors out of Medicare if they are not seeing patients who use wheelchairs. It's a totally reasonable thing to do, right? If doctors commit Medicare fraud, we stop paying them. Is not seeing patients who use wheelchairs equivalent to Medicare fraud? Potentially. Why? Well, because doctors have signed contracts saying they will abide by federal law, including the Americans with Disabilities Act. Right. So there are a lot of ways that we can approach this, and a lot of ways that I want to approach this. But science is slow and incremental, and that, from the outside, I suspect is very frustrating and probably can instill a lack of faith that science can actually solve some of these problems. And I understand why.
Yeah, and I think it also speaks to the fact that we're talking about systems, right? And obviously people are involved in systems and people build and prop up systems. But I think a lot of times there seems to be the skepticism when we say, for example, I go to a job and I'm worried that my boss is going to find out that I'm trans and fire me because that's legal for my boss to do in the state that I live in. And people, I think people outside of these things, and obviously we're going to bring up the P word here and talk about privilege. People see those things as individual situations. Like, well, that person's just an asshole, so just go somewhere else. When what we're really talking about is, we're not talking about like, oh, that guy was mean to me, I'm so oppressed. It has nothing to do with, it's not about the individual experiences. It's about the system that props those experiences up. And I think a lot of times that's where the skepticism comes from people who are like, well, pull yourself up by your own bootstraps, or like, if that doctor didn't give you what you needed, just go to another doctor. And those things simply aren't an option because it's the system that's the problem.
Yeah, I mean, I think I 100% agree with that the system has to be changed, but that's also what's so hard about it. And that's also, I don't for one second actually think that all of these doctors who wouldn't see patients who use wheelchairs are assholes. In fact, Most of them don't even know that it happened. They don't even know that it happened because it was their receptionist who told us this.
Right.
So it is a system problem because the receptionist isn't the one with power, and the doctor probably didn't even make the decision. It was just a thing that happened because the system is messed up. And so I agree that what we really need to focus on is how to change the system to be more equitable. And that's why I believe, and that's why I've advocated the way that I have, both like on many fronts. One is like for doctors to initiate system-wide change. One is for policies to change so that doctors are not encouraged to discriminate, right? In our current system, it's almost like you're encouraged to discriminate because if you take the time to buy tables that lower, or to hire a sign language interpreter, or to do any of these things, you're spending your money, and it may or may not actually be used because you don't even know who's coming in that day. And so, instead, I'm advocating for a system where you know the disability status of all of your patients, where you have a system that accommodates them, where you're not spending money on nothing, and where you can't get away with not spending the money. And if it's those four things, if it's that you know that who's coming in, who your patients are, and what their needs are, you know that if you don't do this, you will not be paid by the U.S. government because what you are doing is illegal, and you have been educated and you understand how to best accommodate these patients, then we've changed the system on multiple fronts to solve a problem that is multifactorial.
Yeah, and I think that's a pretty great refutation to the idea that laws and policies don't really change things, because it doesn't change culture, it doesn't change people's thinking. But I really think it does, and I think that's a great a great sort of way to lay that out. So,
and even if it doesn't, at least the people who need care are getting care, even if the doctors don't like it.
Right, exactly.
I think it goes both ways. I think it's actually a really interesting phenomenon. I am not a scholar on history or anything, or the law or anything else, but I do think it's kind of just interesting from at least what I know from NPR, or maybe Law and Order. No, NPR.
I mean, most of what I know comes from NPR too, so you're good. You're good.
Well, what I think is kind of interesting is that, in some cases the law comes first, right? In the case of hospitals becoming desegregated in the South, they were not going to get Medicare payments unless they became desegregated. And because Medicare brings in such a high percentage of their funding, they desegregated. So that was like the law came first. In some cases, cultural change comes first and the law follows. And I think the sort of gay marriage thing was an example of that there was no law that made gay marriage legal, but we saw a 20-year cultural shift in attitudes towards LGBT people. And as a result, same-sex marriage became legal. It was no longer illegal. So, I think, it's interesting. I don't know which needs to come first in terms of the equity to access to healthcare point, but because I don't know, I'm going to advocate on all fronts and hope that one of them works.
Right. No, that's fair.
But I also think this is, I'm a scientist, so I don't know other tools to use, but it seems to me that because I'm a scientist, I'm going to use science to try to achieve justice.
Yeah, well, and that's fair, because we have to know about these things, and at its core, science is the pursuit of knowledge. So that just makes sense. One other thing that I'm curious about, as far as scientific research, because when I'm talking with someone, trying to engage in discourse with someone who's like, well, this whole trans thing, it's like made up by people on Tumblr, and ridiculous things like that, and I want to send science back to them. And, they do things like they'll quote, what's his name? Paul McHugh, the guy who used to be, some higher up at Johns Hopkins, that is like one of the biggest like anti-trans doctors around. And there is science on trans issues, just using this as a specific example, but you find there's not a ton of it done. So, I'm curious, in your experience, have you seen a sort of bias in the science that even gets done in the first place? Like, not necessarily the results, but just what people choose to study and where people choose to study?
Yes, and that is right. There's a couple of things going on. One is that the culture is ahead of science because science is slow. That's the first thing. So, there's been a radical change in public attitudes towards the trans community in the last 15 years. And there has been a change in the trans community itself in the last 15 years. It has become much more visible, much more politically active. And in some ways, I feel that trans people are much more empowered than they used to be because there's suddenly more of a voice. It might be related to sort of the cultural phenomenon, suddenly there are movies and books and maybe that's it. But whatever it is, there's definitely more visibility, more empowerment. But science is, many years behind. And so that's partly why science hasn't caught up. The second is about funding for science.
Ding, 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 ding. That's what I was going to say.
Science in the United States is mostly funded by the U.S. government. And
are you reading my notes that I have on our Google document? Because I'm writing all the exact same things here.
It's interesting, actually. So when George W. Bush was president, there was I actually at the time was a resident, and I was doing research with a researcher at Brown, where I did residency, who was very interested in HIV and prevention of HIV in drug users and in men who have sex with men. And I remember being in his office and seeing this notice from NIH that said, the Bush administration has said, if men who have sex with men or drug users are mentioned in your grant application, the Bush administration has said your grant will not be funded. I mean, it was that kind of blatant discrimination against grant applications, not against even people, but against grant applications about people. I mean, it was so intense that we, on some level were set back by years of Republicans in power. And so, so that is an example, but also because science is slow and funding for trans health issues is slow, I suspect there will be more science, but I don't know when it will happen. But of course, the last point is trans people, LGBT people in general are marginalized. They are not in power at the NIH. They do not set NIH priorities. And in fact, health services research has not been a number one priority of NIH. NIH is mostly focused on disease-specific basic science research, and health services research, which is the kind of research I do, sort of gets the edges of NIH funding. We don't get a lot of it. And so you have a situation where you have health services research is kind of the marginalized community of the science community in general. And then you have scientists who want to study marginalized communities like LGBT communities or people with disabilities or whatever. And you suddenly see, okay, so that, we're really all at the edges, really just getting the smallest scraps. And it's an unfortunate thing because of course this is extremely important work, and there's so much that we don't know about the trans community, about trans health, about even other LGBT people in the LGBT community, about their issues and their health. I'll be honest, I had entertained the idea of repeating my study for people with disabilities, but having the patient in question be trans, either a trans woman or a trans man, and asking if doctors could accommodate a trans woman or trans man, because I think many would say no, even though it had probably nothing to do with the specialty in question. So I've thought about it, I've entertained it, but it turns out it's a little bit hard to do, and I don't know if I'm the right person to do it. I struggle with that. I am gender nonconforming, but I do not identify as transgender, and I wonder if it should be me or it should be somebody else. And of course, I don't have funding to do it. It would all be
right, yeah.
on a shoestring.
which is what it always comes back to, of course.
Yeah, but it is such an important question. I really have thought about it, and I actually have sort of informally talked to people at my institution about, is this something we could do? Is it something we should do? And I don't have an answer yet. I'm still thinking about it. I hope somebody does it if I don't do it. I am very interested to know how doctors would respond if you say, like, I'm a trans woman or I'm a trans man and I'm seeking care for some unrelated condition. Would they be able to deal with it, or would they say, "Oh, sorry, we can't see you"? And I mean, if we found that a significant percentage so they couldn't see the patient, boy, that would be really important to know. Because
and the frustrating thing is we know anecdotally that thing happens. The question is it systemic? Is it widespread?
Right, and I don't know, and that's why I really have thought about doing the study. I have this memory of watching some terrible MTV show that was like a reality show about people who do strange things, and there was a trans woman on that show who was eating glue sticks or something. I mean, it was something. And she needed to go see this gastroenterologist. And they showed on the MTV show, they showed her interaction with the gastroenterologist. And they interviewed the gastroenterologist. And repeatedly, the gastroenterologist called her he. Oh. And I was just like, it was so mind-blowing that this doctor was so clueless when this was clearly a trans woman. Like, why was this doctor doing this to her? It was just, you know, as a person who, you know, is a tiny bit clued in to the issues that trans people face, I was completely offended by the way this doctor behaved and had just no clue about it. So I do kind of wonder, I mean, maybe we would find that there are really big issues around, you know, across the boards, you know, in a systematic way, that there's systematic discrimination. And I think that would be big news. So, you know, you maybe have inspired me. Maybe I'll try and figure out how to do this study.
Yes. I don't know. You've got my phone number now. I want to hear about this if it happens.
One thing you didn't bring up that I want to touch on to a barrier for more research in this area is publication pressure, which is another huge deal in research. I come from a psychology background, so if this doesn't apply to your area, I'm sorry about that. But in psychology, there is a lot of pressure to, once you finally get the funding to do your study and you run your study, there's your results to be interesting, or else the journals are not going to want to publish it because no one's going to want to read it. If, like, for example, if you do your study and calling the doctors and asking if they'll treat trans people, and 100% of them say, yes, we'll treat trans people, there's no real issue to solve there. You know, the journals aren't necessarily going to be, you know, grabbing your paper to publish it, because there's not really a whole lot of more fruitful research that can come from that. So for that reason, it's really difficult for researchers to break into new areas of research, because like you've mentioned before, a lot of people, it's really safe for your career if you just pick one really specific issue and just kind of do variations on the same study for most of your career, because you know that, you know, you're going to be able to get published by that. But if you want to break into some completely new area, you're not, you know, recognized in that area. And if that area is not something super quote unquote important, like medicine or technology, or something that could have some immediate effect on the population and the health of the population, then, you know, people are going to be reluctant to break into that area because there's a lot of risk involved. You might not be able to get published.
Yeah, I mean, that's definitely true. There are issues around publication bias. Although, as I've, you know, gone a little further in my career, I've realized that it's always interesting. The results are always interesting. And
I totally agree, but a lot of journals don't agree.
I know, it's true. Well, it is true. But, you know, I'm on this study that I really can't mention the results of, but it was looking at if there are accessible tables in a clinic, does the experience of care change for patients? And you know, it was interesting because the results were not that surprising. They were not that impressive, and they were not that, it didn't feel like there was a lot to talk about. But by the end of the day, I was like, you know, actually these results are extremely important, and here's why. Once we talked about it for 5 minutes, I was like, wow, this is extremely important. So I do feel like, yes, there's publication bias, but I also feel like it is on the scientist to explain the results in the context of prior literature in a way that is interesting. That's on me. And I, most of the time, can make that happen. I think most results are very interesting and can be made very interesting. So I don't really say, oh, those darn journals don't. But then again, I've been lucky in that journals have published. I really haven't had trouble with most of the papers I've written getting published. So I don't know what it is exactly. It probably is that I'm a generalist and I just sort of do what's interesting and what's in front of me. And that has made it easier for me to publish, because if it's interesting to me, maybe it's interesting to other people. I don't know.
I want to be clear that I'm not saying it's a conspiracy or anything like that. It's just the nature of the beast. You know, journals have to be able to make money in order to keep printing up journals. So they have to be able to publish research that people want to read.
To me, it's more about funding that's the problem. It's more about the selective funding of, you know, projects that are safe. That's really, if we want to talk about why there's not more social justice research, it's because it's a little bit risky to fund people to do interventions that like aim to change culture, because it's hard to change culture and it's hard to prove that that's going to work. And once you've done it, it's hard to prove you've done it. So I think that is a bigger issue around social justice and science. It's like, okay, how are we going to get funders to believe that we can make these kinds of changes, or to take a risk and let us try? And I think that is the thing I'm struggling with, which is like, I'd love to do a large intervention to address access for patients with disabilities in 6 centers across the United States. But it's going to be very hard for me to get that kind of funding, because nobody is going to want to take a risk on that kind of a project. And so that's what I've been struggling with, and how to go forward is like, how do I get somebody to take a risk on the work I want to do, even though it's extremely important, because it's kind of squishy. Like, the results are hard to show. It's hard to, if I improve the experience of care of a person with a disability, maybe I'll be able to measure it and maybe I won't. And I think that is what is so hard for funders to get their hands around. And that's one of the reasons that we just struggle with getting the kind of funding we need to go forward.
And can you point to any big questions that you've gotten surprising or new answers to that have led to even incremental changes like that?
You mean like interventions, or you mean identifications of problems?
Well, so identifying a problem that then we were able to apply that knowledge to and make things better. I mean, even if it's not a revolutionary, like, oh my God, everything's different now, but you were able to say, wow, we did this work and we learned these things and we're now able to make these adjustments to improve things. I mean, are there any sort of instances where you can point out where something like that's happened as a result of this kind of work?
Oh, that's a good question. Not my work yet. I've only been doing this for about 10 years, so there's not much in my work, but I'm trying to think of other examples in other people's work that have been kind of amazing. The one that comes to mind is a guy, Eric, I can't remember his last name. He ended up becoming the Secretary of Health for Illinois, actually. He, as a fellow, had, when he was a Robert Wood Johnson clinical scholar, he opened a primary care practice in a barber shop, because he wanted to he wanted to identify and treat the health problems of African American men, and he couldn't there was a portion of the population he just couldn't get to because they wouldn't come to the doctor or whatever. And so he said, I'm going to go where this community lives. And he himself was an African American man, which is possibly how he was able to do it. But he opened up a clinic in the back of a barbershop, and when people came to get their haircut, he would take their blood pressure and measure their cholesterol, and he did this amazing thing. He started to see a population of people who formerly would not go to the doctor. And he did it by coming to them, by making it a safe space, by making it feel just like they were getting their haircut. And the result was he really tackled a community problem in a way that was consistent with the values of the community.
Wow, that's really cool. I love it.
Look him up, but I can't remember his last name. His name is Eric. Oh, it's Eric Whitaker.
Eric Whitaker. Okay.
And
Wait, Eric Whitaker, isn't that a writer?
Eric E. Whitaker, MD, MPH. And he is actually really good friends with the Obamas. He and his wife are good friends with the Obamas. They knew the Obamas in Chicago.
Very cool. Well, is there a place that we can point folks to where they can find more about the work that you're doing?
Yes, I will send you some things. Let me think about the best place. I mean, there was a New York Times article about the disability work. There's going to be a Washington Post article. I just talked to a Washington Post reporter a couple of weeks ago, and she said that the article is going to come out in November or in October at some point. So that's another place. but not very otherwise easily accessible. I'm trying to think.
Studies behind paywalls and that kind of thing, right?
Yeah.
Send you the copies of the studies, but I think it might make more sense to just send people. I'll send you the link to the New York Times article. That's probably the most.
Yeah, and I'll add it into the show description box so people can read it.
The big problem, I will send you all these papers because I really thought we were going to have more attention paid to the paper on enforcement of the Americans with Disabilities Act. I really thought that the press would pick up on that, and they didn't. And I was a little surprised because it was such a radical proposition to stop paying doctors who don't see patients with disabilities. It seemed pretty radical, but they didn't really pick up on it. I did talk to the Washington Post reporter about it. We'll see if she actually prints it. I don't know. Gotcha. Her question was, it was interesting. Her question was, what do we tell people with disabilities who want to access doctors? How do we tell them how to access doctors? And I was like, it's a good question, but I think that rather than trying to get 50 million workarounds, we should continue to just address the systematic discrimination that we're experiencing rather than try and tell people, well, you can do this or this. On an individual basis, as a physician, if I have a patient who has a disability who's having trouble accessing care, I try to take over and just find them the care they need. But not everybody has a physician who will be their advocate in that way. And so it's hard. And I don't know what to tell people, except if you're being discriminated against, talk to a lawyer. That is one thing that will move almost any physician to make a change, is if they get a call from a lawyer.
Awesome. Well, this has been a fantastic discussion. I've learned so much, and I really appreciate and I really appreciate the work that you're doing. Thank you so much for joining us.
Oh, thank you. It was great to talk to you.
And that, my friends, is going to do it for this episode of the Gaytheist Manifesto on Secular Media Network. I definitely, again, want to thank Dr. Tara Lagu for her time, for her insight, for the work that she does. Awesome stuff. Very, very exciting. You can find the show on Facebook at facebook.com/The Gaytheist Manifesto. You can email us at thegaytheistmanifesto@gmail.com. I'm on Twitter at GaytheistCallie. You can find the show on Twitter at The Gaytheist, and I bet Ari has an outro.
Wow, such episode. Very science. Many LGBT. Ari Stillman on Facebook, such good talk. aristillman4@gmail.com, much good email address. Such typing, so words, wow. STW podcast, good thanks, amaze, bork bork.
If you want to support the show and the activism we do, you can head to patreon.com/The Gaytheist Manifesto and make a per episode donation as little as $1 per episode. You can also head over to iTunes and give us a 5-star review. That is very, very, very helpful. Before we go, I want you to know that if you're lost, you're hurting, you're scared, if you feel like no one cares and no one understands, you need to know there's a community out here that loves you, cares for you, knows that you're capable of amazing things and that you are worthy of love. If you're struggling, please don't be afraid to reach out. Till next time, friends, this is the Gaytheist Manifesto.